We want to dedicate this DVD of Spinal Biomechanics Made Easy to Dr. R. Gregory, the founder of NUCCA, which was founded in 1966. And he got many, many honors, including one accolade from President Reagan and his wife. Besides that, from the Palmer College of Chiropractic, the David Daniels Palmer Scientific Award. And he also invented the anatometer with Mr. Bernesh, along with the 4 different types of subluxations, and also the 2-point pivot system for analyzing x-rays, which we're going to show you. Besides that, we want to mention Ruth, his wife. Behind every great man is a wonderful woman, otherwise we wouldn't be as great. We thank you. I've been doing this work for 54 years now, so that means I looked at an awful lot of x-rays. And I'm actually the founding directors of NUCCA. But the point of this, I've taken on the responsibility because of all this experience, and what I do have published shows that we can give a good adjustment when you interpret the x-rays properly. To begin with, the high blood pressure study that went all over the world, the 85% of those patients held their first adjustment at least 2 months, and their blood pressure dropped down 17 points. On our chronic fatigue, which is going to be published shortly, 10 out of 19 patients held their adjustment at least 6 months. On the headache study that was published, 35 out of 47 patients held their first adjustment at least 4 months. If I figure out these x-rays correctly, which I'm going to pass on to you, we can give a great adjustment, and if the patient don't hit her head, they can hold the adjustment forever, as long as they protect it. Mental or physical shock can knock out an adjustment. But in the meantime, we're going to present what I can to show you that spinal mechanics can be made easy with a few basic principles. Misalignments of the atlas are very, very small. In fact, 1/3 of the cases are off 3/4 to 1 degree. So consequently, if we're going to measure something from an x-ray, we got to make sure the x-ray was taken correctly. And how do you do this? It's very simple. We have a wall chart with 1/2-inch horizontal lines on them, and we stand the patient in front of this wall chart. And we also have 5 metal markers on them, 1 on the glabella, 2 on the inferior tips of what you palpate the mastoid to be, and 2 on the earlobes. Before we send the patient back, we look at the angle of the right earlobe compared to the left earlobe. And when we go to take that x-ray, if their right earlobe was low 1/4 inch when they're standing, we take that x-ray where the right earlobe is low 1/4 inch when they're sitting down. Now, when you have that x-ray, you know exactly if it's taken the way you want it, and where you may have to compensate some additional lines to give you the true representation of the angle of the head and the plane line. Before we looked at Dr. Chung's earlobes on a horizontal line chart on the wall, we found out that his earlobes were level. So therefore, when I sit him in the chair here, where he is sitting on his his ischial tuberosity and not standing up on the using the acetabulum, he may weaver a little bit. So on the other hand, we are going to see if his ears are level, because his ears are level before on the horizontal line chart. Now the tendency is to push the patient back like this. Now you are putting in distortion because his shoulder is now forward of his acetabulum cavity. So we want him to sit up erect, all right? If they slouch, they will show the twist of the lower cervicals. If they don't slouch, you a truer picture. As you move the patient, you can take the twist out of their body. By the way, you never touch the head on the nasofilm. You never touch the head other than when they drop the heads down. We want the earlobes to be the same. So in other words, you can take the twist out of the patient's head. The head may not be lined up with the body. Don't worry about that. All right. Now his ears are level. But what if he was leaning off to one side, but his ears were level before he sat down? I will move him a little bit to get his ears level the way he was standing. Now, if I have to move him a lot, that means I better stand him up again and take another look at those earlobes. The earlobes have to be x-rayed just the way they were standing. And we put markers, lead markers, on the earlobes and on the anterior inferior tips of what you palpate the mastoids to be. That will help us locate the transfers. So in other words, when I take a picture of him, we will be able to see where the earlobes are because of the lead markers. It's very important, because if you x-ray the head and the ears are where they're sitting different than when they're standing, that will change your plane line, and it'll change where you brace your head for giving the adjustment, and maybe even change some of the mathematics as far as the angle of the head is concerned. All right, earlobes are almost level. So I'm going to move the chair this way a little bit. All right, and I'm going to move the body over here a little bit. Now I got the earlobes level. Now on S0, I will not have him drop his head. Now on the other hand, once the ears are set, and we want to eliminate the primary curve, less distortion of the bone structure, what have you, we say drop your head. But when we drop the head, if they're subluxated, they got tight muscles, their head will drop at a different angle. Now we don't want that. Once we get the ears set and they're sitting up correctly, when we say drop the head, we want the head dropped straight down, whether we're taking an S2, 3, 4, 5, or even a 6 possibly. But the earlobes have got to be the same level as when you dropped it. If it's not at the same level, take that head and put it back where it belongs. All right? Got different muscles. When they're subluxated, they're not balanced, so you expect a different distortion of the head. That would give you a wrong X-ray interpretation. Now, we come over here and we want the head and the back to hit at the same time. So now all right, now, okay, now the head and the back hit at the same time. And we got his head down for this maybe for about an S1. All right, now from the lateral film, we know where we're going to strike this line. I palpate where the mastoid is, where I palpate where I feel it is. We got that from the X-ray. All right, now I put my string back there. It's a little bit above the tip of the earlobe because that's where the mastoid is. And I could look in my mirror. I look in my mirror, and overlapping the string in the mirror. I can get my eye in the right spot. Then I know where I'm crossing his facial features. That was about a 3. I don't want a 3. I want about a 2. Look in the mirror. Look in the mirror. And like string is overlapping. String is overlapping. Now I see where his eye is. I can feel his eye. And now I got an S2 in here. Now I go back here, line up the X-ray head. All right, drop the string. And we put the head clamp down so that it's going to hit the tip of the mastoid. Now I see my head clamp is not coming in equally on both sides. So I'm going to relax the magnet chair and I'm going to move him over. But when I move him over, I want the chair and the body to move at the same time. Don't want to drag the head. All right, I put in the head clamp. All right, now maybe there's a twist in the head. Now we drop the alignment mask, we'll call it. And there's a groove up the top here, and I'll line it with a mark at the end of the room so my one eye is lined up with the alignment mask and the middle of the head clamp, and I can see I'm cutting the middle of his glabella, and I have a metal marker there. So I lift that up and go to take the X-ray.
The first concern in the problem of motion in the subluxation system concerns the forces that the vertebrae exert on each other, internal forces. Given the forces, we seek to know the manner in which the vertebrae move under the action of the forces. This is the subject matter of mechanics proper, and one of the reasons why we post X-ray every case immediately after the first adjustment, to learn how the vertebrae that were displaced, as seen in the pre-X-rays, moved under the external force of the adjustment. Dr. R. Gregory.
I have about 50 sets of X-rays of the 5 different types we want to demonstrate. And each set of X-rays will show you something a little bit different. But to start with, we're going to show you 3 sets of 5 different types and try to get you oriented to the small details that go into analyzing X-rays. The importance of the brainstem has been demonstrated by the research projects that have been published. But the point is, why do we have to worry so much about the brainstem area? Although chiropractors have talked about everything as being pinched nerves, there are also proprioceptors in the neck, and especially the proprioceptors between the condyles and the lateral massive atlas. Now remember this, every vertebra in the spine is interlocked with the pre- and posterior apophyses and the discs. The only vertebra in the whole spine that you possibly can move is the atlas. There is no bony interlock on the atlas. And the atlas is locked in the subluxated state or the non-subluxated state. We have 50 sets of X-rays on the high blood pressure where we X-rayed them 8 weeks after we adjust them or we didn't adjust them, proving that the atlas was locked in the frontal plane and the transverse plane. The only area the atlas is not locked is when you nod your head. So consequently, with this information I'm giving you now, we're going to try to orientate or coordinate everything that we're going to demonstrate to you. So otherwise, we're going to use models, and we're going to talk to some of you as beginners, so that you could understand why we have to align our body to give the adjustment so that the subluxation is reduced proportionately. Basically, we would like to have the neck balancing the head, but we're working with some very small measurements. So otherwise, we want to go into details what we have to take into account when we use the atlas as a lever to move the head and neck back to the vertical axis, and also taking out the rotation of the vertebra of the atlas. And also, when the lower neck can be off its vertical axis, there could be a twist in the lower neck. So we hope to demonstrate all this. But basically, we want to come back and go through the basic principles, how we analyze x-rays. Now, assuming, this is very important, assuming that the bottom of the skull is level, and about 10 or 15% of the time, the bottom of the skull is not level. But we're going to assume that we have a very symmetrical vertebra in the head and neck to start with. And then we'll go into other combinations later on. But, all right, in our work, we divide up the skull above the squamosal suture. This is a straight line. And then we draw a line right below the posterior arch of atlas, and we draw a line through the middle of the neck. And therefore, this is what we call perfect. The plane line, this is called the plane line, is level. The head is in the vertical axis, and the lower cervicals are balancing at right angles to the atlas. All right, from that point on, there could be 1,500 different combinations of directions, a permutation of 5. And if we understand all the different directions that head and neck can be twisted, we know how to lay the patient on the table and take the proper angle in the adjustment. So let's consider all the 4 different variables that we go into the what we call the different height vector in one of the axes that we measure that we're going to take when we adjust the patient. First thing is there is the angle of the head has to be considered. All right, we're going to give you a dimension for that. Then did the atlas go off to the right side? Did it go off to the left side? Did the lower neck go off to one side or the other side in relationship to the angle of the head? So taking all this into account, including the circumference of the conjugal circle and the circumference of the superior portion of the axis body, all these things are taken into account. So we're going to cover all that. So when you look at an x-ray and you measure all these different angles, we'll know exactly, at least to start with, at what angle we're going to adjust the patient in the frontal plane. Then there's also the transverse plane, which we'll go into detail on that. In adjusting, and when we look at x-rays, we have to consider the fact there's a height vector and there's a rotation vector that we combine to find our adjusting angle. We'll call these 4 elements into the height vector. Head tilt is 1. For every degree the head is tilted into the side of the subluxation, we take off 1/2 inch from the height vector. The degrees not to be exceeded the degrees of subluxation. So in other words, if I have a 2-degree head tilt and only 1 degree subluxation, I would consider that as only 1 degree, and we'll take off 1/2 inch from the height vector. If we have 2-degree head tilt and a 4-degree atlas laterality, we would take off a whole inch from our height vector. Plane line. For every 3/16 of an inch, we add 1 inch to the height vector if it was high on the side of atlas laterality. Or we subtract 1 inch for every 3/16 if it is low on the side of the atlas laterality, or a fraction thereof. Conjugal over axial circles. Generally, the conjugal circle is smaller than the axial circle. It's very rare you ever find it otherwise. For every number difference between the conjugal circle and the axial circle, we'd add 1/2 inch to the height vector because we want to move both these circles equally. When we use the atlas as a lever, we have to take this into consideration. Say the average conjugal circle is 3 inches and the average axial circle circumference is, say, 6 inches. 3 to 6, that's 3 numbers difference. We would add 1.5 inches to the height vector, so both the conjugal and axial circle will move at the same rate. Upper angle against the lower angle. On a type 1, when the lower angle of the lower cervical is in relationship to the upper angle, if there's 4 degrees difference, we would add 1 inch to the height vector, or a fraction thereof. On a type 2, if the lower angle is greater than the upper angle by 4 degrees, we subtract 1 inch. We try to get both the angle of the head and the angle of the neck to move proportionately. Whenever the upper angle is greater than the lower angle, we do not add or subtract. These are the 4 elements that we figure in the height vector.
Use 1 inch in the adjusting vector, anterior or posterior, for every degree of rotation of the atlas on the vertex film. Your episternal notch should be within 1 inch of where it was calculated from the films.
Now we want to talk about another portion to our adjusting vector. It's the atlas in the transverse plane. The atlas can go forward or backward, depending upon whether the atlas went right or left. They go forward or backward. The atlas can rotate, and we want to know when the patient is subluxated, which way did the atlas rotate. And sometimes even in a vertex x-ray, we can demonstrate that there's rotation in the atlas. In fact, that's where we get our measurement of the rotation of atlas is the vertex x-ray. We don't use the foramen magnum to do this. We use the fact that the atlas rotates in relationship to the whole head, which we'll cover in detail. We just want to let you know that these are the basic measurements we're going to be using.
We use a variable vertex square and overlay the vertex film aligned to the atlas. We then draw a line above it and or below it. When the percentage of atlas laterality reduction and the reduction of the lower cervical angle to the vertical axis do not reduce proportionally, the adjustment vector should be corrected. The adjusting vector is then changed to go higher or lower, so both angles will reduce proportionally. Atlas laterality is paramount. The percentage of the reduction of atlas rotation has to be considered when changing the adjusting vector. The vertical line going through the center of the grid carrier bisects the skull when it is placed properly, and the rotation of the atlas vertebra is measured using this line on the vertex film. The transverse center of the atlas is measured from the center of each bilateral mass.
Deterioration of the spine is not a matter of age. Deterioration of the spine is a matter of the fact you've been out of adjustment for many years. So look at this. His age, I put it right in the x-ray, 76. The man enjoyed good health his whole life. His spine was balanced. At that time, I used the best way I could to check him, a neurocolometer and leg check. At that time, we didn't have the anatometer or what have you. In 1959, we would like to have you see that the discs are all evenly spaced. He has most of his own teeth here, and there's no real changing shape of the vertebra. The curvature is very good. So the reason I'm showing you this x-ray is to show you that when people have subluxated for many years, it shows up as damage to their spine one way or another, exostosis, disc degeneration. When I look at an x-ray, I can tell the patient when they had their first accident. I am generally within 1 to 2 years. Here's a young man. He's 24 years old. He's got 24 years of adaptation. If you look right at this point right here, I got a little arrow right here. You see how as the weight shifts forward and the vertebra, the bodies of the vertebra are taking the weight. Over here, you can see there's a little starting to be a point over here, a little exostosis. That is because the weight is falling forward, not on the pre- and post-sacral apophyses. So over here, I said he's got 24 years of adaptation because he probably was born with forceps or had a traumatic birth delivery. And then you see a little point on the vertebra changing shape. That's the way you can detect that. You might also detect it by some calcification on the anterior longitudinal ligaments. And the minute you see a little calcification there, it took 20 years. From that point on, you can start to estimate when the patient had the first accident. I don't remember how old this patient is, but basically, we got 30 years of adaptation there. You can see the curve is reversed, and you can see that there's a little exostosis on this vertebra right here coming to a point. Remember, if the weight is falling back here, you don't get the change of the vertebra on the anterior aspect of the bodies of the vertebra. Age 40, he had his first accident 20 years ago, and you can see the lipping of the vertebra right here. He's age 59. As far as I'm concerned, he's got 60 years of adaptation. Look at the disc degeneration. Look at the spurring of the vertebra, changing shape of the vertebra. You can see the anterior calcification here where the bone want to fuse the other. No disc over here. It took 60 years to get that way. 60 years. Unless he was a football player. That could account for some of that. 75 years old, 75 years of adaptation. The man never walked straight in his whole life. Look at the spurring of the vertebra, changing shape of the vertebra. It looks like the second and third vertebra are fused together right here. No disc. Look at the disc degeneration here. This is as bad as they come. Although you might see some Maurice-Strompeld's disease where the vertebrae fuse together. It's calcification of the carotid artery. Ordinarily, you will not see this on X-ray. It is rare. You see that line right here? As far as I'm concerned, I could be wrong, but that's the calcification of the carotid arteries. And it took many years to get that way. Of all probability, the vertebral arteries have enlarged to make up for the difference, which all four arteries go to the circle of Willis. They weren't even aware that they had maybe the restriction through the carotid artery. On a type 1, as the atlas is knocked off we'll call this the right side. The head could be leaning that way or it could be in the vertical axis. Question is, after we figure out the four elements, on a type 1, we generally would brace the head at the center of gravity. You can use a flat headpiece or a round headpiece if you pull the ear down. On a type 1, you want to brace the head at the center of gravity, which is 2.5 centimeters above the auditory meatus. And flat headpieces are all right. A round headpiece you may be able to use and brace the head, pull the earlobe down, but brace the head at the center of gravity. And then, of course, on a type 1, you take a high contact and use the atlas as a lever to move the axis body and all the cervicals back to the vertical axis. So we'd have generally a height vector like this and moving the atlas, and all the cervicals would be moving over to the vertical axis. Think about the cervicals as a pyramid. They're all interlocked, all except the atlas. Here we have a 22-year-old patient on type 1. Look at the abnormal curve we have here. And they're starting to show some activity here where it's starting to maybe change shape a little bit. But otherwise, he's 22 years old and certainly has a reverse curve. This is the prenasal film, and the head was leaning considerably. Now, whenever the head is leaning, you have abnormal magnification in the X-ray field. You're never sure of the measurements because of the unequal magnification. So what we do, we force the head straight, and the head is in the vertical axis. The atlas is locked in the frontal plane and in the transverse plane. So when you force the head straight, you're not moving the atlas in relationship to the center of the skull, but it just carries with it. Here your posterior arch is slightly higher the way it should be, and on this X-ray, it measures laterality of left 3/4 of a degree. 1/3 of atlas subluxations, 1/3 are about 3/4 to 1 degree. So consequently, that is the reason we have to be so careful and understand magnification in the X-ray field. Now, on this X-ray, the prenasal film, without forcing the head straight, was atlas over the left 1.5 degrees. When we forced the head straight, it was only left 3/4 of a degree. On a type 1, where the head is leaning so much, we're going to brace the head a little bit higher than the center of gravity, maybe another 1/16 or 1/8 of an inch. When the head is leaning that much, you can brace the head higher than the center of gravity, by a little bit. Now, ordinarily, the axis and atlas are always lined up, with the exception that if the lower neck is off like 6 degrees here, and the axis body is not too large, circumference, the odontoid will move. So we have atlas laterality, we have axis body center, then axis spinous. One more time, when the lower neck is off 6 degrees, it can move the axis body 1 degree at the top. And so otherwise, in the old way of figuring it, whenever the axis body moves 1 degree more, we would add 1 inch to the height vector, if you wanted to look at the old way of measuring. Now over here, the plane line was high, 8/16, so on the plane line, I had 2 3/4 inches. The head tilt is leaning away from the vertical axis. I didn't subtract anything for head tilt. Conjugal axis circle, 3/8. There's 5 difference. I add 2.5 inches for the height vector. Whenever the upper angle is less than 1, we'll call it 0. 0/6. All right? We drop the fraction at the top, and we pick up the fraction at the bottom when we look at X-rays. So we have 0/6, and for every 4 degrees difference, we add 1 inch, so it comes out to high 1.5 inches. So my height vector on adjusting this patient was high 6 3/4 inches. Now, when it's high 6 3/4 inches, the mental marker here is what you palpate the mastoid to be. This is what you palpate. Here is your transverse, all right? Now, there's a difference here of about 1 inch. I might say this. There's a 20% magnification in the X-ray field when you are looking at an object this far from the film. So if this was high 0, you'd take the contact right here. But when you go more than 4 inches high, you'll raise your contact another 1/4 inch higher because you got the depth of the skin. If you start out here, you're going to pass it up. And you want to raise your height vector so that you can catch the atlas transverse. Now you notice the lower angle came down to 1 1/4 degrees from 6 degrees. And if anything, when the lower angle does go down to 0, you say, hey, maybe my height vector was not high enough. You see this a 1/16 inch, and with an arrow going down here, that means that the head was not x-rayed exactly the way I wanted. We look at the earlobes in relation to our horizontal line chart, and these are the ear markers. I wanted this x-ray to be tilted, or meant the head and neck in relation to the x-ray another 1/16 of an inch. Where I mark that down, that means that everything's going to go that way another 1/16 of an inch to the vertical axis. For a type 1, this is a tremendous reduction. Remember, it was only off 3/4 degree laterality. But when the lower neck comes down to what it did, you had to remove the atlas laterality. Notice the posterior arch here is slightly elevated. That's the way you want it. If your posterior arch is low, we do not use that x-ray. On the vertex films, I designed a new filter where we cut off all the radiation from each side. Here's a nose, and over here you can see the glabella marker. Over here something happened, we couldn't see the glabella marker. We marked the pre and post portion of the lateral mass, and we use our variable vertex square. And on this one it says anterior 3/4 degree. And over here it said there was no rotation in the atlas. So besides us taking care of the lower neck, we also got the atlas rotation out. And the filters we use, there's 9,000 of lead here, 6,000 of lead here, 60,000 on each side. The only place there's no lead attenuation X-ray beam is right in the center. That is why we get such sharp X-rays. Whenever you look at a pre-X-ray, always figure out, do I have to increase my KVP a little bit? This is a hair darker, maybe I increase my KVP, 2 points on the KVP scale. Always mark the card at what KVP and time you gave each X-ray. This is a 16-year-old boy. You can see his wisdom teeth haven't come in yet. Look at the angle of the neck here. That is, for a 16-year-old, that's the most horrible spine I ever saw for a 16-year-old. And when the weight is falling this far off center, there's got to be a twist in the cervicals because the weight is being distributed unequally across the pre and post apophyses. On the pre-X-ray, his head was leaning severely to one side here. And of course, I couldn't accept that. When the head is leaning this way and we analyzed the central skull line, it came out to a right 1.5 degrees. But remember, we have unequal magnification X-ray field. Now here, it's our label, we force the head straight. And when we force the head straight, so we have equal magnification, the atlas didn't move, the atlas is locked in a subluxated state or non-subluxated state, it came out to left 1 3/4. So here, look at this. We had right 1.5. When we forced the head straight and got equal magnification X-ray field, we had left 1 3/4. It's a matter of knowledge to know that there's unequal magnification in the X-ray field. Now let's go back to this X-ray over here. I try to mark the spinuses of the cervical spine, and his neck is off right 10 3/4 degrees. No, I've seen him 16, 17 degrees off, but not when the bottom skull is level. That's pretty severe. So the plane line, we got 7/16, 2 1/4. Conjugal axial circle, 3/5 plus 1. Head tilt, we didn't add anything for head tilt because the head is tilted away from the subluxation. No angles. What we'll call this 1, we dropped a fraction, 1/11. That's 10, that would be plus 2.5 inches. So my height vector, 5 3/4. Now we adjusted this case. The upper angle came down to atlas lateralis is 0, axis body center is 0, axis spine is 0. Look at the twist of the spinuses here. Look, when you balance the pre and post apophyses, look how the spine straightened up. It went from 10 degrees to 2 degrees. You might say, well, I should have went higher to get the lower angle. But as you go higher, you're hitting the atlas transverse, and you're hitting the axis body, which brings the lower cervicals back to the vertical axis. As the twist comes out of the lower cervicals, the spinuses come around to 0. There's no twisted vertebra on the vertical axis. The whole thing is always try to get the neck in the vertical axis, and you'll have no twisted vertebra. All the way throughout the spine. There's a transition from one side to the other. The one that is in the vertical axis, there's no twist in the vertebra. I got all this information from Dr. Gregory. Of course, we want to mention the vertex X-rays. We measured the pre as anterior 1.5, and it came down to 1. So you say, well, I got to add more to my rotation vector next time I adjust the patient. There may be a longer lateral mass on one side than the other. So it's possible that you might want to consider when we have abnormality here that maybe at 1 degree may have been normal for the patient, didn't move any further. We were not made in the machine shop. All vertebrae are not totally symmetrical. The bottom of the skull is not always level. Here's an 18-year-old boy. Again, look at the abnormal curve going forward instead of the opposite direction, 18 years old. And when the curve is like that, and you can see a point on the, he was probably born with forceps and never walked straight his whole life. I want to show you this x-ray now. The arch is too high. We don't use an arch this high. Look how high this arch is. I'll try to draw this line here. It's too high. But basically that arch should have only a couple of degree angle to it. We cannot see the attachment of the posterior arch to the lateral mass if you have a small misalignment. We turn that x-ray down. But here's a little bit of a problem case that we worked out, and you'll come across them. So we want to make sure that you understand the process. Now over here, we have a right subluxation of 2 3/4 degrees. The head was tilted 1 degree into the subluxation, and that's the way we mark it, 1 degree into the subluxation off the vertical axis. Lately, I've been marking when the plane line is right, I'll say, okay, we're not going to change the plane line as far as the way the head was x-rayed. If the head was x-rayed properly, the plane line, we mark it okay, as long as the earlobes are where we expect it to the horizontal line on the grid. You may notice that I have a horizontal line embedded in my grid carrier. I have a vertical line embedded in my grid carrier. On this particular case, the height vector was 3 3/4 inches. After I adjusted the case, my lower angle went from 3 3/4 degrees to 5 degrees. That tells me I adjusted the case too low. I have to go higher. My next one, I went higher in my adjustment angle, and it did not move. I had 5 degrees here. In other words, I got to lay the first post, second post. I still ended up with a low angle of 5 degrees. It tells me that I had adjusted the patient at a higher angle yet. Now, this is my third post. Very rarely do we ever send anybody back for a second post. But I'm using this to illustrate if you have a problem, you can work it out. There's my second post, and my third post, which was my final post. I went from a high 4 to a high 5 on my height vector. Now, if you see, the lower angle, the upper angle came down to 1/2 degree, which was off 3 degrees, I think, and the lower angle now is off to 3 3/4. And when you get the proper height vector, the lower cervicals will move. And on a type 1, you have to have the lower cervicals move to reduce atlas laterality.
On types 2, 3, 4, and abnormal type 1, use the round side of the headpiece.
Now we're talking about a type 2. The neck is knocked off to one side, the head compensates and goes off there. Now this is a severe angle. So we have atlas laterality on the right side. On a type 2 now, we would brace the head below the center of gravity. Depending upon the head tilt, we would take a 1/2 inch off the head tilt. For every degree, it is listed off the vertical axis like this, not to exceed the amount of degrees you have atlas subluxation. And then, of course, we also would say, well, if it has 1 degree head tilt to 2 degrees atlas subluxation, we would brace that halfway down between what you palpate the mastoid to be and the center of gravity, halfway down. If you had 1 degree head tilt and 3 degree atlas laterality, we would go 1/3 of the way down. So in other words, there's a certain relationship to where you're going to brace the head depending upon head tilt and relationship to atlas laterality. Now on type 2, we want the lower cervicals to be in the vertical axis. So we can see maybe an angle of your hand about like this so that the force comes around here and it'll bring the axis body back. That's the way it functions. So it's probably a low angle and force comes around and brings the axis body back to the vertical axis. On type 2s, if I don't have 2 degrees more head tilt, I don't worry about the head tilt anymore because I'm going to brace the head at the tip of the mastoid. The weight of the head will fall over. I'm not worried about the 2 degrees laterality. I'm worried about the lower cervicals being off the vertical axis. So I may go even lower than what I figured in the x-rays, so the force coming around will bring the lower cervicals back to the vertical axis. Now, there is a possibility on a type 2 subluxation that you might have to give them 2 different angles to the adjustment. One angle to lift up the head, and the lower cervicals did not come all the way over. So therefore, I would take a second angle to get the force going around here to bring the lower cervicals back to the vertical axis. Now, that is rare, but basically we try to figure out one angle to the adjustment to take care of the head and neck back to the vertical axis. Now, here's a man, age 55, and I marked down 50 years of damage. Here, you can see the vertebrae are starting to fuse together here. See the calcification anterior longitudinal ligament. All right. And by the way, you might wonder how we explain X-rays to the patient. First thing, we show them that there's an abnormal curve. We can show them the exostosis and disc degeneration. But the main thing we want to show them, and I left the markings on this for this particular purpose. We use a spring showing there's a coupling action between all the vertebrae. This spring represents their spine. But you can show them one hip is higher than the other, kicks over the lumbar area, and then you got adaptation. And you could be like that also. This is the way we explain it to them. At the base of the brain are two brain centers that balance all the muscles of your body. This brain center says muscles contract. It's a facilitator. This brain center here, muscles don't contract the muscles too much. It's an inhibitor. This is like a gas pedal to a car, and this is like the brake or the governor. These two brain centers got synchronized, balanced, coordinated. If the first bone gets twisted, it upsets its balancing mechanism, and up goes one hip. If you pinch the bases of your brain, all the research projects shows you it affects you physically and mentally. It goes up into your brain, down your spine. The point is, you want better health in the future, we have to make sure there's no stress at the base of your brain. All right, I want to show you something that we don't talk about in general. Because, as I said before, your bodies were not made in the machine shop. The bottom of your skull could be not level with the rest of your skull. So here we have a central skull line, but over here, as we take our protractor and put the protractor on the central skull line, and we draw a square line here, there's a square line, you'll see the condyle is shorter here than over here. And generally, if you have a shorter condyle, the lateral mass will be high on the side of the shorter condyle. One more thing here. When we have a short condyle, I want the lower angle to be opposite the upper angle. On a type 2, this is very important. Look, the neck is going at an angle this way. But on the other hand, if I got a short condyle, the atlas lateralis will not reduce all the way because of the short condyle and the high axis body on that side. The plane line will come all the way down, but I want the lower angle to be the same as the upper angle. That's because the high axis side on the superior surface of the axis body is high on that side. In this particular case, it figured out my height vector would be a high 4. But remember, I wanted the neck to go the other way, so I adjusted it to a high 3, anterior 2. I dropped it another inch. This is post X-ray. I have an upper angle of 3/4, lower angle of 1. As far as I'm concerned, it's in all the way because the bottom of the skull is not at right angles to the rest of the skull. So what did you learn here? You learned here that it wouldn't hurt to put a square. In fact, you should do it in all your X-rays. Just glancing at them doesn't give you the information. That you got to take your protractor or any square with the central skull line, mark a square line here. Then the lower angle, and you put the protractor on there or anything that will give you another square line here. Possibly you might see a short condyle disappear when the head is a vertical axis and it's not torqued in any way, shape, or form. I suggest you mark all X-rays with a square line right above the condyles. On a type 2, you definitely want that the lower angle be opposite the vertical axis so that it balances up with the neck, which we did over here because I lowered my height vector. The pre and post vertex X-rays. We use a variable vertex square unit to measure rotation. We marked the front of the vertebra, the east lateral mass, the posterior east lateral mass. Where it was anterior 1.5 degrees on the left side, we came down to 0. All right. Another type 2 case, 22 years old. His curve is pretty normal. This is a normal type 2. By the way, the eye is a little bit low here. He's looking down a little bit. So when you take the lateral film, they should not be looking down. Anything over S0, you want to drop the head down. But the atlas bobs up and down. So whenever you take a nasal film, it's not the way you expect it to be, you take it again. Simple type 2. We have a right 1 3/4 degree laterality. The head is tilted 4 degrees off the vertical axis. So therefore, I'm subtracting 1 inch for head tilt. The plane line is low 3/16, and we subtract 1 inch for that. Condylaxal circle, 3/5. That's two numbers difference. We add 1 inch. Angles. This is up 1. Well, we drop the fraction of the upper angle, pick it up for the bottom angle. It's 1/5. So we subtract 1 inch. So when you figure out the height vector for the frontal plane, minus 2 inches. Post X-ray, we had normal for atlas laterality, normal axis body, normal axis spinous. But look at this. We went from 4 3/4 degrees lower angle to 1 3/4 degrees lower angle. That tells me we may have gone lower. So next time I adjust this patient, instead of taking it as a low 2, I'd probably take it as a low 3. Vertex X-rays. Or remember, the line going through the center of your equipment. When you put the glabellar marker on center, the chin on center, and the head clamp goes in a posterior inferior portion of the occiput. Remember, posterior inferior portion of the occiput, you lined up the head to your equipment. So the line going through the center of your equipment, the vertical line, is bisecting the skull. We measure rotation of the atlas in relationship to the whole skull. Don't use the odontoid anymore or the foramen magnum anymore. They are abnormal. Dr. Lyle Sherman and Dr. Blair both came out with tremendous statements that the foramen magnum is not sending the head more than half the time. We're showing you 2 vertex X-rays. I want you to look at the odontoid in relationship to the white line. All right? If you notice, the odontoids are identical. All right? In fact, maybe this one is a little bit less. As you move the atlas, the odontoid will move with it. The odontoid will move 2 millimeters on a 3-inch consular circle for every 3 degrees of laterality. So when you look at vertex X-rays, if they are taken identical, you should find the odontoid within 2 millimeters of where you expect it to be after you allow for atlas movement, which will carry the odontoid. If you're off more than 2 millimeters, you don't know which vertex was correct. The odontoid should be where you expect it to be within 2 millimeters if you allow 2 millimeters of the odontoid movement for every 3 degrees of atlas laterality on a 3-inch consular circle. This man's 46 years old. You can see he's got 46 years of damage here. Look at the vertebra changing shape here. Minimum of 30 years. That's closer to 40 years. In the central reticular formation of the brainstem lies the facilitator and inhibitor of all the muscles of the body. If this vertebra gets twisted, it upsets the balancing mechanism here, up goes one hip. Then this develops that way. This is a type 2 on the left side. It looks like a short condyle, but it wasn't. Here we put our square lines, and you can see it looks a little bit short on one side. And whenever a head is not in the vertical axis, or any vertebrate is not in the vertical axis, you're going to have distortion in the X-ray field. You have to know that. I had a 4-degree atlas laterality, axis body center, axis spinous, all 4 1/4 degrees, and I thought I had a short condyle. So I lowered my height vector almost an inch and 3/4, just low 1. Now over here, if you notice that it did work out all right. They came down to normal on atlas, axis body center, and axis spinous. But what I'm trying to show you here, this is very abnormal. Here's your mastoid. This is what you palpate the mastoid to be. And here's your atlas transverse. Look at the distance we have between here. If you were to adjust into this area, it would pull the ligaments would pull the atlas towards you. This is quite abnormal to have this kind of distance between the atlas transverse and what you palpate the mastoid to be. It's very important. Now, if I were to adjust this as a low 1, I would consider this point on the out of the skin. If I were to adjust it on the high side, I would consider this point. If I adjust it straight down, I would consider this point. So in other words, what part of the atlas transverse are you going to contact? People just don't understand that you could have malformation in more ways than one. If we divide each lateral mass, you would get this line here, which would be left anterior 2 degrees. Now this is very sharp X-ray. Here's your foramen transversarium. If I draw a line through the foramen transversarium and measure to the line going through the center of the head, it would measure anterior 6.5 degrees. So the question is, when we went to bisecting each lateral mass to get our true rotation, that is more correct than if you use the foramen transversarium. It is a very important point to make, and here's an X-ray that proves the point, that the middle of each lateral mass does not line up with the foramen transversarium. And this is as sharp as an X-ray you'll ever get to prove that point. Now this is the pre. The post, it went from an anterior 2, I checked it out as left anterior 2, and it ended up as left anterior 1, and I called it abnormal. This is very significant to understand that the foramen transversarum and each lateral mass does not line up the way you think that if everything was totally symmetrical, it wouldn't be that way. And these are very sharp films. Notice that we cut down more radiation by I'm using about 60,000 lead from each side of the nose, and I can see my glabella marker, I can see in my nose, and that's all I'm interested in the vertex film. If my glabella marker is off, I'd say 20% magnification, I'd go over 20% back to the central line if my glabella marker was off. But look at the neck. The neck is on center. The glabella marker is on center. It's a perfect x-ray. On a type 3, the neck is at the vertical axis and the head dropped down like so. They are referred to this as foramen magnetic pressure. But I would like to also repeat one more time, I'm interested in the proprioceptors between the lateral masses and the condyles. Although the proprioceptors throughout all the muscles there, I think this is the beginning point of where the body, mentally and physically, the body starts to deteriorate. The proprioceptors between the condyles and the lateral mass. So on a type 3, it's all head tilt. So we would brace the head at the tip of the mastoid, and it may figure out a high 1, maybe on the height vector, but I like to take them at a high 0. Generally, my type 3s, I take it a high 0, and of course I take in rotation vector, but I brace the head low to lift up. If you brace the head here, and you give the adjustment at the tip of the atlas here, you have a shearing action. That'll lift up the head. So that's on a type 3. Now here we have age 43, and I think you call this anterior posticus. Look at that line there. But you can see there's a little change in the vertebrae here. Type 3 is very simple to understand. You think about it, foramen magnetic pressure, all right? These are the pre and post. Now notice I put down OK over here as the plane line being the way I expected. The earlobes are, I want the earlobe markers to be on the vertical axis, and that's the way it came back. So I marked the plane line as OK. On a type 3, the head turns into the subluxation. The lower neck is 0. The atlas is lined up with the lower neck, but the head turned into it. Foramen magnetic pressure, we'll call it. What do we do here? Plane line is minus the 16th. I put down minus a quarter. The head tilt is turned 2 degrees into the air, and I could go only half as laterality, so I'm minus 3/4. For every degree the head is tilted into the subluxation, I take off a ½ inch and no more than a ½ inch. And the degrees here should not exceed the degrees here, so I said minus 3/4. Condyloaxial circle, 3.5 over 7, 6.5, so we'll call it 3 over 7. That'll be plus 2 inches mechanical leverage. Upper angle, relationship to the lower angle. When the upper angle is greater than the lower angle, we don't add or subtract anything. So it comes out to plus 1. I think I mentioned to you on a type 3, I generally take it a high 0. So we adjust a high 0. Come on over here now. The plane line is okay. Got it marked okay. Ear markers are the way I expect them to be. The lower angle is off a ½ a degree. The upper angle, atlas lateral 0. Axis body center 0. Axis spinous left 1. Over here, the axis spinous was left 3. So I'm not worried about that at all. Another type 3. Got the abnormal curve here. Age 44. You always wonder how long they've been subluxated. These are my pre and post. Let's look at it's a right listing. The head is tilted 2.5 degrees into the subluxation. So what here? We got plane line plus the 16th. I have plus a quarter. Head tilt. Head tilt is 2.5 degrees. But remember, I'm not going to exceed atlas laterality. But it comes out to minus 1.5 inches height vector. Condyloaxial, 3 over 8. Remember, you pick up the fraction on the bottom, drop it on the top. So that's 5. So I had 2.5 inches height vector. Upper angle, relation to the lower angle. When the upper angle is higher than the lower angle, we don't add or subtract anything. So on this particular one, it says adjust high 1.5. I didn't. First thing is I'm going to brace the head at the tip of the mastoid. The tip of the mastoid on a round headpiece. On the tip of the mastoid that you palpate it to be. You're not palpating the mastoid itself. On the live person, you're 3/8 of an inch off. In the magnification is magnified 20%, you're off a ½ inch. So I'm going to brace the head at the tip of the mastoid. I want the head to fall over, and I dropped it 1.5 inches. I'm going to take it a high 0. All right, now here's the post x-ray. We took it at a high 0. And normal on atlas laterality, axis body center, axis spinous. The lower angle, 1/4 degree. Nothing wrong with that. This is what you palpate the mastoid to be. Here's your mastoid. Here's your transfers. I'm taking this high zero, and I'm thinking about this point right here. Here's your atlas transfers. Now, if you want to be real technical, for every 32nd of the nose, if you take this S0, for every number of the nose shadow, this moves up 1/32nd of an inch. It's in the monograph, way back when. Then you got 20% for magnification, so I take off another 20%. So I would take a contact on this a 1/4 inch below what you palpate the mastoid to be. I'll show you rotation. Now, this is abnormal because ordinarily when your head turns into the subluxation, the vertebra goes anterior. So here we have a right listing, the vertebra went posterior 3/4 of a degree. We mark the anterior and inferior portion of each lateral mass. With a variable vertex square, we can measure the rotation of the vertebra in relationship to the whole head. Notice the glabella marker is on center. Notice the neck is on center. Now, one more thing we want to show you again. There was a posterior rotation where the head turns into it. It should be an anterior. They probably had their head twisted someplace along the line. But in the meantime, you have to adjust it as a posterior 3/4. All right. Notice the odontoid here in relationship to my white center line. Notice it over here. If we move the atlas 3 degrees, it should move the odontoid 2 millimeters. And I said if you're within 2 millimeters of where you expect it to be, you're comparing two accurate x-rays. If you brace the head properly and get the neck is almost immature, but get the neck on center. But when you brace the head, the inferior portion of the occiput, you're going to center the bottom of the skull consistently. Here we have a man 47 years old. As far as I'm concerned, he's got 47 years of damage here. Look at the disc degeneration here, the exostosis here, the lipping of the vertebra. And by the way, sometimes you'll see this on the nasal film. You can look at the pre and post apophyses on nasal film, and you see also them changing shape. These are the earlobe markers. In relationship to the horizontal line, I said I probably wanted the right earlobe low 1/4 of an inch, and it is low 1/4 of an inch. I'll have to show you how we mark that on the card before we send the patient back. If you have the glabella marker on center, and the zygomatic arch, the mastoids, and everything else that don't line up, you know you took the x-ray correctly. And then, of course, you send the patient back, and they turn the chair so the glabella's off to one side. Maybe 1 out of 20 cases, the glabella may not be in the center of their head. But you got to center what we call it's actually the superior orbital notch on there. It looks like eye sockets. You want to get that centered. I'll point that out in other x-rays. Type 3, the head is tilted 4 degrees, 2 degrees laterality. Remember, degrees of tilt of my head cannot exceed that of laterality, minus 1 inch for head tilt. The plane line is low, 3/16, minus 1 inch. Conjugal axial circle, 3/6. That is 3 numbers difference, half a number and height vector for each number, plus 1.5. Angles, when the upper angle is greater than the lower angle, actually it's type 3, we don't add anything or subtract anything from the height vector. So it came out minus 1/2 inch. So I adjust this case minus 1/2 inch. I'm not going to go any lower than that. Look at the post x-ray. Normal, right 1 on the axis spinous. It was right 3. The lower neck is on 0. On type 3s, it's all head tilt. You brace the head at what you palpate the mastoid to be on a round headpiece setting. Oh, by the way, there should be an anterior rotation. It was a posterior rotation. This is what my new filter. Here's the right posterior one. After that, with this way, mark it 0, 0. We mark the anterior portion of each lateral mass, posterior portion of each lateral mass. Neck is on center. The glabella is off just a hair. Notice I came over my line a bit because the glabella was off center. 20% magnification X-ray field. A type 4 is the head and neck are leaning into the side of the subluxation. This is a type 4. On a type 4, depending upon the head tilt, I know where to brace the head on the side here. One more time, for every degree the head is tilted into the subluxation, I subtract a 1/2 inch from the height vector, not to see the amount of degrees the head is atlas laterality. So I would brace the head low. That would take care of the head tilt. Now, once you figure in conjugal axial circles, forget about it. Don't ever look at that again. They may figure that I should maybe have a high 1 on in the adjustment, in the height vector. I would go to maybe high 2 or 3 because I want that neck in the vertical axis. So the weight of the head will, when it braces low, will take care of the upper angle, and I want to take a little higher angle here so the force hits the axis body here, and that force will bring all the cervicals back to the vertical axis. That's it. I don't worry about 2 degrees of head tilt. When I can brace the head low, the head will fall over, and I want to make sure that I use enough height vector to bring the lower cervicals back to the vertical axis. Here we have a head that is severely tilted, and we know we have unequal magnification in the X-ray field. On this X-ray, it measures right 3/4 of a degree laterality. Now over here, we got our marker on, force head straight. Now we only use this X-ray for atlas laterality. The atlas is locked in the frontal plane and the transverse plane. So when you force the head straight, you didn't move the atlas. It stays right with the skull. When we forced the head straight, it came out right laterality, 2.5 degrees. So this will force straight, right 2.5 degrees. All right, let's mark this down. Atlas laterality, axis body center, and axis spinous. Those are our measurements. What did we figure and how did it work out? The plane line is minus 6/16. So that's plane line -2. Head tilt was 8-degree head tilt. But remember, we're not going to use those degrees to exceed the amount of degrees of atlas laterality. So over here, I put down head tilt -1.5 inches in height vector. Console axial circle, I guess 3/5.5, we'll call it 3/6. We pick up the fraction on the bottom, and it goes plus 1.5 inches on the height vector. When we add it all together, it comes down to a -2. I'm not going to worry about 2.5 degree laterality. I like to say generally 2, but 2.5 degrees is not too bad. I'm going to brace the head at the tip of the mastoid that you palpate. But if I do that, I want to get the lower cervicals back to the vertical axis. I want to apply more leverage to the axis body here to bring the lower cervicals back to the vertical axis. So I did not adjust it as a -2. I adjusted at a high 0. The weight of the head weighing 10, 12 pounds, if you break the tip of the mastoid, 2.5 degrees, which I think would take care of it. And of course, it depends upon one's ability to adjust. Atlas laterality is paramount. If you miss the lower angle, it's not as bad if you miss atlas laterality. You got to get atlas laterality. Atlas rotation sometimes is also a big factor, or it should be also considered a big factor. But the lower cervicals, if you don't get the lower cervicals back to the vertical axis, it may not be as stable, but I don't think it will hinder the patient's progress. But it just won't be as stable. Here's the post X-ray. It came down to 0, 0, 0, normal, normal, normal. The lower angle was right 1 degree. Look at the way the head straight out and to the vertical axis. If we draw a straight line from the middle of the cervical area, remember we got a white vertical line here, just match it up. From the middle of the cervical area, look at the neck is off to the right here. Look at the head is off to the right. All right. Now let's look at the post X-ray. Draw a vertical line from the middle of the neck. The neck is in the vertical axis, the head is in the vertical axis. You can always draw an extra line to show it to the patient an improvement. It looks like the vertex were not important at all. In my office, we take on a new patient. We do the pre and post X-ray at the same time. In other words, we adjust them the same day. We ask them to be here for 2.5 hours, and I do run patients in between. The filters here, there was a number 5 filter. That's 9,000 lead here, 6,000 lead here, 60 on each side. And here's the glabella marker. We want the glabella marker to be on center. You go over 20% if you wish, because it's magnified 20% in the X-ray field. There was a 2.5 degree atlas laterality. If you move the atlas 3 degrees on a 3-inch concentric circle, the odontoid will move 2 millimeters. Look at the space between the white line and this width of the odontoid. Come over here. Look at the space here between the lateral masses of the odontoid and the white line. It moved 2 millimeters. In other words, these are 2 identical X-rays because the odontoid matches up. If ever they don't match up, you don't know which one was correct. Here we have one age 21. And you can see here, the vertebra changing shape a little bit here. He's been subluxated his whole life. Exostosis here. He never walked straight his whole life. First thing here, we force the head straight. There's a lot of head tilt here, and it comes out to atlas left 1. Atlas laterality left 1. But we forced the head straight, and it came out to a right 3/4. Here's your posterior arch, just perfect. Head was forced straight. We got it marked on the X-ray, all right? And it came out right 3/4. By the way, look at this film here. This is your mastoid marker here. That's your mastoid marker. Here's your atlas transverse. That's buried. It's way up in here. Generally, your atlas transverse is down here. I never found an atlas that's so buried that I could not move it. That's a big statement. But in all my 54 years of practice, I've never found one I couldn't move, no matter how much was buried. Let's go to this X-ray now. This X-ray measured atlas left 1 degree. There was a tremendous head tilt, and we used 1/4 straight. When we forced straight, it was right 3/4. 1/3 of atlas subluxation, or 3/4 to 1 degree. If we are going to analyze a set of x-rays, let's make sure we have the proper set of x-rays to analyze. Otherwise, you're wasting your time. On this x-ray, I wanted to drop the angle of the head a 1/2 inch. So even though we did put our basic lines on our plane line, bisector of cervical angle, I put another marker here. I drop and going over another 1/2 inch of the way the skull is angled, the way the plane line is angled, and another angle over here to show everything is going off to one side, another 1/2 inch from what the x-ray was. Generally, if it's a 16th or an 1/8 inch, I might even do that to give you the true angle of the patient. When you look at a patient's earlobes, before you send them back to be x-rayed, and you mark the right ear low a 1/4 of an inch, when you come back, before you mark the x-rays, take another look at the head again. They can change from one second to the other, I suppose, but the point is, before you go finish marking the x-rays, check the earlobe level the second time. Once before you send for x-rays, once before you mark the x-rays. And make sure that you are looking at the proper angle of the head and for the plane line and where you're going to brace the head. So you see where we're going to add additional lines to give us a true perspective of the subluxation. All right, how do we figure this x-ray? All right, let's go with plane line. It was 5/16. I add another 1/2 inch, and we could call it 13/16. For a 13/16 on plane line, I minus 4 inches for the adjustment. Head tilt. Head tilt was 7 degrees because I increased from a half to 2 to 7, and I only got 3/4 degree laterality, so I'm only going minus a 1/2 inch. We never exceed the degrees of head tilt to the degrees of laterality. Conjugal axial circle, 4/6. That's two numbers minus 1. Angles. The upper angle is 3/4. The lower angle, 1 3/4. We drop the fraction here, pick up the fraction here. So that is 0/2. So that's for every 4 difference with 1 inch, so I have minus a 1/2. It comes out minus 4 inches. I just said high 0 because I'm going to brace the head at the tip of the mastoid to take care of my 3/4 degree laterality. And I want to bring the neck back to the vertical axis. So I'm changing this 4 inches, and it's buried besides. It's buried way up into here. Get your hand as high as possible in between there. On the post x-ray, it came down 0, 0, 0. This is atlas, axis body center, axis spinous. 0, 0, 0. But it's another thing I want to show you here. Look at the cross line here of the superior ocular orbit, ocular notch, over here. See this? The x-ray should be turned another 16th of an inch this way to get those equal. That's a very important part to look at. In other words, by me raising the height factor 4 inches, it worked out right. I got the neck to the vertical axis. The vertex. You could see this. It was right anterior 3 degrees. Even though the vertebra was buried, when you make contact, push the skin ahead. But look, it was anterior 3 degrees, came down to 0. This is the only spot that is not attenuating the x-ray beam. Let's look at the odontoid. Right? See, here's the odontoid in relation to the white line. Here's the odontoid in relation to the white line. They're within 2 millimeters. Right now, I want you to see, this is the right mastoid. All right, this is the right rami, and I have this minus 1/2 inch. That means, and it was an anterior, that means I'm going to be way up in here to try to take contact to catch it. From the x-rays, you find out where you're going to put your hand to take the contact. And that's all prefigured. You don't go for a palpation to locate atlas transverse. You don't try to palpate it. Age 57, but this is what I wanted to show you. I think they call this the broken Georges line. See this line? It's not lining up here? And I told her she had an accident 40 years ago. How did I date that 40 years ago? It's very simple. Look at the exostosis here, the damage that took place in this area. She had a fracture back here, but you can see the vertebra starting to change shape. It took 40 years for it to change shape like that. That's why I dated an accident 40 years ago, and she confirmed it. The patient looking straight up. Now look at the rami here. All right, they're lined up. But look over here. You see both sides of the atlas. That atlas is tremendously tilted to see both sides. As long as this is lined up, that means the x-ray was taken at that proper angle. And you see both sides. Here's one side of the art, here's the other one. These are the pre and post. Let's look at the pre. On this one, I wanted the head to drop down another eighth of an inch on the right side. That's this my arrow, my minus an eighth. In other words, the earlobe markers weren't the way I wanted them to be. And an eighth of an inch isn't too bad. So this is the plane line. I moved the plane line down an eighth of an inch over here. I moved the plane line over here that way. I moved the central neck line over here an eighth of an inch. That gave me the true perspective of the way the neck is in relationship to the vertical axis. Atlas right 8 3/4. Axis body center 8 3/4. Axis spine is 8 3/4. Generally 6 degrees is maximum amount that the atlas can move. I think what Dr. Gregory said one time 7 degrees. But anyway, let's say 6 degrees. I took my protractor, any square, anything, a line here, and I put a line over here, square at right angles to my central skull line, a line over here. I did this lower neck also, put a line over here at right angles to the central line. I want you to see the difference here. Here's a condyle line, here's the bottom of one condyle, here's the bottom of the other condyle. In relationship to the square line, look at the distance. Whenever you have a short condyle, or the bottom of the skull is not level to the central skull line, the axis body will be high on that side. There's never only one abnormality. This is what you're born with. It's part of our measurement. It's not part of the patient's sickness at all. It's just part of the way we measure. That's all. It's up to us to reduce it all the way, but all the way won't be at 90 degrees. Figured out, just in case minus a quarter, I went to a high 2 because I wanted that lower cervical to be over here. It's tilted 5 degrees, and we're talking about 8, so I braced it halfway down. I wanted the lower neck to be the same as the upper angle. Now this is my post x-ray. I came up with 5 degrees at the upper angle, and I got 4 degrees at the lower angle. I'm happy with that. I don't know if it'll go any further, but that was a tremendously abnormal short condyle and high axis body. So I reduced it from 8, we'll call that 9 degrees to 5. I'd reduced it 4 degrees. I'm happy with that. The patient did respond. But remember, I went up a little higher on the vertexes. Right, posterior 1/4 degrees. We use a variable vertex square in the central skull line. The line going through the center of the equipment, which bisects their skull. And it came down to 0, the way we measure. Notice the odontoids in relationship to the white line are identical. So and the neck is on center. Actually, I would expect the odontoid to be moved over another couple millimeters. But they're very close. They're within 2 millimeters. They're within 2 millimeters. I'm happy. Dr. Gregory named the first 4 types, and then later on he came up with this one for abnormal type 1s. The head and neck are leaning away from the vertical axis, and you got right subluxation here. No matter what your height vector figures out here, say it figures out a high 4, you subtract 2 inches from the height vector, and you brace the head halfway down between the center of gravity and the tip of the mastoid. Brace the head halfway down. Think about this as Freeman magnet pressure. So if you brace the head halfway down and you cut 2 inches from the height vector, the head will lift up and remove your subluxation. The muscle will bring the lower cervicals back to the vertical axis. It works at least 95% of the time. Although you cannot see this, I use a red pencil marker when I show the patient the x-rays. They may remember more about what you're trying to tell them with the red marker. Of course, notice here that the neck is going in this direction, And it took many years. And here's your facilitated inhibitors in the central reticular formation of the brainstem. That's why the spine's got out of balance, because atlas is locked in the wrong spot. It upsets its balancing mechanism. Up goes one hip, and their hips and knees wear out. Their whole body starts to wear out. But the point is that it affects the autonomic nervous system. And the high blood pressure, we showed that we affected the high blood pressure. It shows that we affected the autonomic nervous system. And when you affect the autonomic nervous system, it affects everything. Now we're in what I call abnormal type 1s, where the head and neck are leaning away from the vertical axis. This is head and neck are leaning away from the side of the lateral. It's the left listing. And it came out left atlas left 3/4, axis body center. That axis body is all left 3/4. All right, we drew a line through the center of the skull, and we drew a line through the cervical area. We drew a vertical line up from the middle of the neck That's parallel to the white line embedded in the equipment. You can see, and this is the right side of the film. You see the head, neck leaning away from the right, the head's leaning away from the right. If you see this okay here, I'm just starting to do that. It shows that the earlobes is where I expect it to be in relationship to the white line when I send them back to be x-rayed. I'll have to show you the card how we do that. The plane line is high 5/16 in relationship to the opposite side. So I got 1 3/4 degree added to my height vector for my adjustment vector. Head tilt. When the head is leaning away from the vertical axis, we don't add to it. Condyloaxial circle, 3/8. That's 3/8, 5.5 plus 2.5 inches for mechanical leverage. Upper angle against the lower angle. We drop the fraction here. We pick up the fraction here. That's 0/2 minus a half. It comes out to plus 3 3/4 inches supposedly from my height vector in the frontal plane. As I told you, on this type, we minus 2 inches. Minus 2 inches from the calculated height vector. So it's plus a high 1 3/4. Here it is. I adjust a high 1 3/4. Oh, by the way, when we brace the head on this one, we brace the head halfway down between the center of gravity and the palpated tip of the mastoid. That is the formula we use. And here's the post x-ray to prove it. 0, 0, 0, atlas lateralis, atlas axis body center, axis spinous. You couldn't ask for a better x-ray than that. Everything is 0, lower neck 0. So in this particular set of x-rays, I proved my point. And what I'm trying to tell you is how to take abnormal type 1s. These are my pre and post vertexes. The way I measured it was anterior 1 3/4, and it came down to 1. So possibly I should add another, maybe a half inch to my rotation vector to the next time I adjust this patient. But I was happy with what we did. All right, here we have an abnormal type 1, all right, and the age is 32. And, basically the spine should be like this, and it's leaning forward. Here's the pre and post abnormal type 1. What did we do? Over here, the x-ray was, I wanted the head to be tilted another 1/8 of an inch. Here's minus an 1/8 of an inch with arrow going down. All right, this is my central skull line. I'm moving it over 1/8 of an inch. It's right 2 degrees. Over here, if I didn't move over 1/8 of an inch, it'd be plus 16th. I add 1/8 of an inch, it's plus 3/16. And over here, the neck would be leaning a little bit more to the right. All right, so what did we do here? Head tilt. If it's away from the vertical atlas subluxation, we don't add anything for head tilt or subtract anything for head tilt. Condyloaxial circle. Drop the fraction here, pick it up here. That's 3/8. That's 5 numbers difference plus 2.5 inches for mechanical leverage. Plane line is plus 3/16. Here we add a whole inch. If ever the plane line is low at 3/16, we subtract that inch. So let's put all this together now. It comes down to plus 3.5 inches. The formula, take off 2 inches. That means I'm adjusted high 1.5 inches. I'm going to brace the head from the center of gravity, which is 2.5 centimeters above the auditory and tip of the mastoid, halfway down, wherever you palpate the mastoid to be, to lift up the head. We'll call it frame of magnetic pressure. Lift it up. The lower muscles will bring the neck back to the vertical axis. Now let's go over here to the post x-ray. How did it work? The head is in the vertical axis. We got atlas lateralis, axis body center, and axis spinous, and the neck is in the vertical axis. How about that? There's a B filter used and a number 2 filter used. On all my x-rays, the filters that we use that I designed many years ago will give you the sharpest x-rays possible. Now over here on the lower neck here, this is the only spot that there's no lead filtration. All these extra parts of the head here, notice we didn't burn out the parietal region here. We didn't burn out the arch of the posterior arch of axis. We got the neck showing through here because we have 8 or 9 filters that we use between the nasal and vertexes, and we can pick out how much radiation we want to hit where. So you have to have the filters. You have to have a chin center device, which I designed. And of course, you got to close down the port of your x-ray tube housing, which I showed you how to do that. That gives you 50% sharper x-ray. Age 51. There's 50 years of damage. See how the vertebra changed shape? Patients that had suffering with migraine headaches. It's an abnormal type 1 where the head is leaning away from the vertical axis, not very slightly, but it's leaning off to the right. I want you to look at the axis spinous. Look at the curve we have here. Sometimes these curves are greater curves. And there'd be no twisted vertebra on the vertical axis. Make sure you understand that. So if I get that neck to vertebral axis, I expect the twist to come out here. So in a case like this, I want a little extra leverage to bring that over to the vertical axis. All right. The plane line was okay. All right. We had at 2 degrees atlas laterality. All right. Let's go over this. Plane line 5/16. Plane line 1 3/4 inches. Head tilt. We don't add anything to head tilt because head's leaning away from vertical axis. Carnes lower axial circle. 3. Pick up the fraction 3/6 plus 1/2. Angles. 2 over 1 3/4. We call that 2. They're the same angles. Don't add anything. It come out to plus 3 1/4. Looking at the standard procedure here, I'm minus 2 inches because we consider this an abnormal type 1. It figure out a high 1 1/4. I adjusted this case maybe just a little bit lower in the respect that I wanted to have a little bit more force against this curve here. And this is the post X-ray. Look at the curve that you had in the twisted spinous came out. So what I'm trying to illustrate to you is that when you see a curve in the cervical spinuses, try to add a little bit more force vector going against the curve or with the curve. Think that you have to add another inch to bring that curve out of the cervicals, after the cervicals come back to the vertical axis. Draw a line through the spinuses if you have to. Double check that. Let's look at the vertex of that case. It was a left posterior 2 1/4, and it came down to 0, much straighter. Notice the odontoids. The odontoid in relation to the white line are the same. Remember, she only had the left 2. So I'm within 2 millimeters where I expect it to be. The whole object is to understand that you have twisted cervicals in the nasal view. That means you need extra leverage as you bring the lower cervicals back to the vertical axis, but you need extra leverage to take the twist out of the cervicals. Mind you, if ordinarily the cervicals has a straight line on the spinuses, but when you have a twist such as you see here, can you understand you need maybe a little extra leverage? Bring the cervicals back to the vertical axis. I'll need extra leverage to take the pre and post apophyses here and the spinuses back to the vertical axis. This is what we call a type 1 abnormal, where ordinarily we had a high 5 inches vector. We cut 2 inches off of it because it's an abnormal type 1. That's what I use. But we took off another 2 inches because of the twist of these cervicals. So I adjusted this case as a high 1. And now this is the pre. You see the twisted cervicals here? All right? And after we adjusted the case, this is your post. See how 90% of that twist came out? Now that twist radiated all the way up and down the spine. So if ever you see a twist in the cervicals, not a straight line or like we ordinarily see, you need a little extra leverage so that as you bring this back, you want to bring the lower cervicals back to the vertical axis. And to do that, you have additional resistance here. That additional resistance has to be overcome by changing your height vector maybe another inch or 2 inches. Now, this is a very difficult case. First thing, I think age may be a factor when you have complicated cases and you're trying to straighten them out. We have twisted spinuses here that radiate all the way down the spine, and we have a short condyle. And when you have a short condyle, the axis body is high on the side of the short condyle, low on the side of where the condyle is lower. And whenever you have a short condyle, whenever you have laterality, you want the lower neck to be opposite the laterality. After you reduce the subluxation, and you have 1 degree in the upper angle, in the left side, you should have 1 degree on the right angle to balance it out. So you wouldn't want the lower cervicals to be at 0 if you have a short condyle and the upper angle is still 1 degree. You can overcompensate for trying to straighten out the lower angle. You don't want the lower cervicals to be at 0 if you have a short condyle of left 1 degree or 2 degrees. You want the lower angle to be right 2 degrees. Here's one of the most severe cases I came across where we have twists in the cervical vertebra that radiate all the way down the spine, but we can see it on the nasal film. But look at these axis spinuses from the axis on down. Except for I don't remember seeing one that. Remember that radiates back and forth throughout the spine. Now, in this particular case, I'm trying to get the neck back to the vertical axis, and although it called for a high 4 3/4, I adjusted this case as high 0. High 0 would get me my atlas laterality. Now, this is a case where we adjust them 2 different angles because the fact is that the lower cervicals twisted so much, I did not expect the lower cervicals, the twist to come out to be back to the vertical axis. So in this particular case, we adjusted a high 0 That's dropping it almost 5 inches to bring the neck back to the vertical axis, which, remember, I think age is a factor that they don't want to straighten out that much. And then after I adjust my zero, like a post x-ray showed me that I have to go a little bit lower. After we got laterality, I go to a low 2. A low 2 straightens out the neck even further. Once you get atlas laterality, you could gun, for, as we refer to it, to get the lower cervicals back to the vertical axis. Now here's a post x-ray on one of the times I did adjust them. And you can see, look at the way the spinuses are twisted here. And remember, that radiates all the way down the spine, back and forth. And then look how they straightened out. There's no twisted vertebra on the vertical axis. That came from Dr. Gregory, and of course that's the way it works out in practice also. You want to get every vertebra in the vertical axis, and your pre- and post-sig apophyses will have equal weight on each side, and will take the twist out of the spinous. Sometimes you get cases where you have to adjust them at 2 different angles. The first angle is to get atlas laterality. The second angle is to straighten out the lower cervicals. Sometimes these lower cervicals don't want to move, but you have to get atlas laterality first. On this x-ray here, I want to show you this. We put a square line right here and a square line here, and you can see the condyle is shorter here. Now here's a square line here and a square line here. You see the axis body is high on that side. That's also go on the post. You see that the condyle is a little shorter on this side, the axis body is high on that side. You'll never have only one malformation. There's always coupling malformations. If you got one malformation, you got to have something to make up the difference. And I always say you weren't made in a machine shop. But don't ever use that as an excuse not to reduce atlas laterality. You got to do the best you can and always reduce the atlas laterality as much as you can. Now, this is our patient card. It took me many years to work out. This is the inside of the card where you mark down every time the patient comes in. You got to mark something down every time they come in. I think you're legally responsible to do that. All right. Now, this is the other side of the patient card. This is the date that they come in, what you've done, the charges, what they paid, and what their balance is. All right? It's very simple. We have an office visit. We have the adjustment charge, the anatometer charge, examination, and cervical x-rays. Those are the codes that we use. All right? Now, let's go here. This part I want you to understand. When the patient comes in, before we send them back, and we put the markers on them, we use the wall chart. Where is the right earlobe in relationship to the left earlobe? It could be minus 1/4 of an inch. Take your own x-rays that way. Make sure the right earlobe is low 1/4 of an inch. Before you mark the x-rays, take another look at the earlobes again. After you give them adjustment, before you send them back for the post x-rays, is the earlobes level? Mark it on the card that you expect your earlobes to be level when you take the post x-rays. After you look at the x-rays, and the head is in the vertical axis, where are the earlobes? Would the earlobes be right? It could be low, it could be high. Earlobes are not necessarily 100% indicative of the central skull line. The earlobes could, if the head's in the vertical axis, the right earlobe may be low 1/8 of an inch. Sometimes the glabella is not in the center of the head. When you take your nasal film, you got the glabella marker on there. The glabella marker is on the center of the film, but the rest of the head is not symmetrical. So whenever you go to repeat that x-ray again, say glabella is going to be right or left. If it says it's going to be right, or it says it's going to left, take off the right one, it's going to be left 1/8 of an inch. All right? So you know whenever you go to take another nasal x-ray, your glabella is going to be off left 1/8 of an inch. Filters. What filters are we using? Every time you look at a film, you say, is there any way to improve that film? Before you mark it, is there any way to improve that film? You could raise your KVP to or lower it to KVP. You could change the time. You could change the filters. If ever you want it more black and white, you cut the KVP 10% and double the time. That will give you a short scale, more black and white x-ray. In some cases, you have to do that. Now over here, even though you have a chart, when you look at the x-ray, what is the KVP you're going to use? Every time you take that x-ray, you could change it. The nasal view is on that side, the vertex view is over on this side. So it's at 74, maybe it's 3/4. Now over here, conjugal axial circle. This goes back to the Groslik days. You got 3/12, say. Oh, 3/12. That in the lower neck is going to move very hard. When you got a 12 axial circle, which is possible, your lower neck will not move that easy. This center of gravity, that's 2.5 centimeters above the auditorium hiatus. And here's the tip of the mastoid. This is a left listing, right listing. All right. So where are you going to brace their head? If the head is tilted 2 degrees on 4 degrees of atlas laterality, I'm going to brace the head from the center of gravity to the tip of the mastoid, right here. Put an X right there. Where are you going to take contact? Say the contact is right lateral to what you palpate the mastoid, so you put a 0 there. But on the other hand, what if it's buried and your contact's way up here, way up there, say minus 1/2 inch? So from the card, you got everything. Where you take the x-rays, what the time is, and the vertex, the nasal film, where you take contact. Now here, if they had previous manipulation, if they ever had their head manipulated, great big X. And the reason you do that is when you x-ray the patient, you're x-raying where the last manipulator left it. There's a good chance it may not be the same, we can go out the same way. And I have a little something here, estimate of degeneration. If they have an accident case, you may not want to leave that out or something, but you could put down 40 years. Every time you look at a patient, you say, hey, you have 40 years of degeneration there. It's important that you know where to put your hand to take contact. This is your transverse tip as you look at a lateral view. This is the middle marker that we put on what you palpate the mastoid to be. This is your rami of your jaw. The question is, the depth of the skin is about 1 inch from where the transverse is, and you want to precede the contact because of that depth of that inch. So therefore, if you only have posterior rotation, you take your contact way back here, all right? If you have anterior rotation, you take it right off the jaw. If you have a low vector with anterior rotation, you go low and take it this way, all right? For a small height vector with 3-degree rotation, you take it at this angle. For a big height vector with 4-degree rotation, you're way up here and you take it at this angle. In other words, visualize that the transverse is 1 inch below. Now here, for a height vector with severe rotation, you get your hand as high as you can between the mastoid and the jaw. All right? For a rotation with a small height vector, you take it over here. So it gives you an idea that you always have to concentrate on where you're going to put your pisiform. Assuming that the superior tip of the atlas transverse is at the same level as the middle mastoid marker. Mastoid marker, transverse. The transverse may be in a different location, but always keep in mind that it's about 1 inch deeper. Now the question arises, when do you re-x-ray patients? First thing you got to remember, you should do the leg check. The leg check will show you what side of the brainstem has the biggest stress factor. Now, in checking legs, they should always have the same leg shortage. If ever the opposite leg goes short, there's no doubt about it, you got to pre-x-ray them. In other words, the vertebra went out in a different direction and they're pitching the opposite side of the brainstem. So an iron rule that we will always go by, whenever the opposite leg goes short, you re-x-ray them. All right, that's one thing. Now, on the other thing is, remember, if they've been to other chiropractors or anybody manipulated their head and neck, we might even throw in a severe accident. But basically, a severe accident, generally the vertebrae go out the same combination direction your whole life. All right, but otherwise, always have a suspicion. The next time they go out, they may go out slightly different or greatly different. And when as time goes on, maybe several months or a year, and when you got a second set of x-rays, they show you're giving them the proper angle to the adjustment, you're more sure of yourself. As we look at earlobes, when they come in, we got it marked on their card. I will never adjust a patient after the first visit unless I look at their earlobes again and see if the earlobes are where I expect it to be. See if the head is in the same angle, because you may want to brace the head different, change the angle of your adjustment slightly different. But the point is, anytime the patient has had any problems at all, and they're not responding the way you expect, assuming they're sleeping correctly, you should take what called check x-rays or pre-x-rays. Pre-x-rays, right, if ever the leg is short 1/8 of an inch, and they turn their head and it gets a little bit shorter, they need an adjustment. All right. So on the other hand, no matter with the leg check, the anatometer, even with the laser lights my wife has invented, it's fantastic. There is nothing 100% correlative as to when you have a perfect adjustment, holding a perfect adjustment. Sometimes check x-rays will give you the additional detail you need to see how if the patient is holding their adjustment correctly. With the laser lights, on the anatometer, how accurate you could be with laser lights, if they have a quarter-inch torque between the shoulder girdle and the pelvic girdle, which should show up as 4 degrees on the laser lights shining on the chart, they still have stress at the base of your brain. But what also I'm trying to get over to you is x-rays are our final proof. There's nothing we have at the present time. The laser lights, I say, are 99%, but x-rays are 100% that show you that you gave them a perfect adjustment. So otherwise, there's reason to re-x-ray patients if you run into trouble, or if their head takes on a different angle, or the second time you go to x-ray them, if their head has been to a previous manipulator, all right? Sometimes they get massages. Don't ever adjust a patient on the old x-ray information if they had a massage. That's an ironclad rule in this office. So otherwise, I did my best to give you all the information I can with what time we had. It's possible to be an addendum to this. I have more x-rays to show, but at the present time, we've given you three sets of 5 different types of subluxations, and hopefully that you will use this information and you'll improve your ability to become a greater chiropractor and help your patients, and this work will live on for the benefit of humanity.